G'day everyone. We've got a couple of minutes to talk Takotsubo Cardiomyopathy. It's also known as broken heart syndrome and stress-induced cardiomyopathy, and it may represent 1 to 2% of patients with suspected ACS or STEMI. So what is it? It's a syndrome and is characterized by transient regional systolic dysfunction, usually affecting the left ventricle. The wall motion abnormality typically extends beyond the territory of a single epicardial artery, and there's no obstructive coronary lesion. The pathogenesis is not entirely clear, but catecholamine excess is postulated to be a mechanism, as is microvascular dysfunction and coronary artery spasm. Takotsubo is taken from the Japanese word for an octopus trap, which has a shape similar to the apical ballooning appearance in the typical form of this disorder. This type represents about 80% of cases. Variants include a mid-ventricular type, in which the apex is relatively spared. This type represents almost 15% of cases, and other less common variants include a basal variant, and there's focal and global variants too. A lot of stats you read about Takotsubo come from the International Takotsubo Registry, which includes about 1,750 patients from 26 centres in Europe and North America. In this registry, 36% of patients had a physical trigger, such as acute respiratory failure, sepsis, being post-surgery, things like that. Almost 28% reported an emotional trigger, and interestingly, nearly 30% had no evident trigger. Roughly 90% of cases are women, and the mean age is in the mid-60s. The most common presenting symptom is acute substernal chest pain, reported in about 75% of patients. Dyspnea is the next most common, reported in just under half of patients. About 10% of patients develop symptoms and signs of cardiogenic shock. If this happens, it's worth doing a quick bedside echo to look for severe left ventricular outflow tract obstruction induced by basal hyperkinesis. This is important to detect because management changes. When LVOT obstruction is present, we avoid inotropes and give beta blockers instead. Inotropes can worsen the degree of obstruction. If the patient was really hypotensive, a pure alpha agonist like phenylephrine or failing that metaraminol would be a good adjunct. ST elevation is frequent and is found in about 44% of patients, most commonly in the anterior precordial leads. ST depression is less common, found in about 8% of patients. TROP is usually elevated too. Patients who survive the acute episode typically recover systolic function within 1 to 4 weeks, but the risk of severe in-hospital complications is similar to that of patients with acute coronary syndrome. So that's Takotsubo cardiomyopathy in a nutshell. Thanks for listening.